I mined a study from Monagle, which is in the business of brand experience across all industries, but their health report came out this week. And the key thing for health systems in that report was patients as consumers want wellness from the hospital system coupled with kindness and efficiency. But it's wellness. It's not just take care of my heart failure or my type 2 diabetes. It's get me well and keep me there, hospital system. And also at the same time, be personalized, be kind, give me time and respect me, and be innovative with AI. So it's really interesting. The demand is there for wellness for hospital systems. And the only way hospital systems can do that is to collaborate with companies that have the wellness mission too.
Welcome to Beyond the Blueprint, a podcast designed to empower healthcare professionals, enabling them to improve care delivery through integrated design and technology innovation. My name is Greg Malkery, and joining me is my co-host Keith Washington. Whether you're redesigning a hospital, launching a new digital initiative, or just curious about the future of healthcare, then you're in the right place. Let's explore together what's possible when we go beyond the blueprint. Well, today we're going to be exploring consumer healthcare. Most people want care that's simple, connected, and fits naturally into their everyday lives. Unfortunately, most hospitals are still building care systems around themselves rather than the patients they serve. In this episode, we're going to explore how hospitals can close the gap by building trust, delivering personal care, and making healthcare feel more human. To help us break this down, we've invited Jane Sarasohn-Kahn. Jane's a nationally recognized healthcare economist, advisor, and author who has spent the majority of her career studying how technology, policy, and culture influence healthcare delivery. Jane, thank you for joining us today. Would you like to start by giving us a brief introduction from your background?
Thanks so much. That was really well put, how you defined what I do, that convergence. So my training at University of Michigan, all of my college education was done in Ann Arbor at that great school, the Big House. And I studied economics as an undergrad and then worked for a few years and went back to grad school and did my graduate degrees in public health and economics and forged a degree at the time in health economics, which didn't really exist at U of M. So we made it work. And ever since then, I've only ever been an advisor across the health system for 10 years with big accounting-based consulting firms when there were big 8. And now, of course, there aren't 8 anymore. The last firm I worked with that was one of the big accounting firms was Touche Ross in London, which then became Deloitte eventually. And then at that point, I started my own practice because I wanted to become a mom and didn't want to be a partner in the traditional way in one of those firms. So now that child is getting married in a few weeks. So it's been a journey being a working mom and building my own business. But anyway, this is my passion. My work is working across the health ecosystem in an advisory capacity in the U.S. and in Europe.
Wow, Jane, I did not know your daughter was getting married because my son is actually getting married in 2 weeks in Cabo.
My goodness, mine in about 4 weeks.
Okay.
Congratulations.
Great. Yay, awesome. Love. Yeah. Love is alive.
Now, before we dive into today's discussion, I want to recognize our valued sponsors who've made Beyond the Blueprint possible, Storage Systems and Simplify Medical. With their support, we're able to bring you insightful conversations around healthcare design and innovation. If you enjoyed today's show, I encourage you to subscribe so you never miss a future episode.
All right, why don't we get started and let's ground our conversation. In layman's term, what does it mean to be a healthcare consumer? And how has this term changed over the past few years?
Yeah, I started to use that word consumer a while ago. My client was a big pharma at the time I was speaking with about the widening copays between a generic drug, a tier 2 and a tier 3, meaning off formulary. And we started to see copays going from $5 or $10 to $10 to $20 to $40 in the third tier. And at that point, I said to my client, again, this is a while ago, Mrs. Jones is going to fill a prescription for her husband's, say, statin at the time. This is before we had generic statins. And at the retail pharmacy, at the point of purchase, not mail order yet, she's faced with a dilemma. It's her husband's birthday. Does she buy the Norelco razor or fill the script for 40? And I said, at that point, Mrs. Jones is a consumer. And that's when I started to use that word. Paul Krugman started to write in the New York Times, healthcare can never have consumers. And I was early to say we're a consumer when we're all of a sudden dealing with out-of-pockets that feel like retail at that moment of truth at the point of purchase. To me, that has evolved over time, because not only are we dealing with out-of-pockets for copays for specialty drugs that could be, 5 or 6 zeros after a number, but we're dealing with people lacking transparency, empowerment, and you can be an unempowered consumer or an empowered consumer. So it doesn't mean I think it's a good thing to be a consumer. It's just, for me as an economist, very practical, it is what it is. And so people are dealing with this now every single day, whether it's dealing with a deductible, a copay, or shopping for shoppable healthcare services. Not every healthcare service is shoppable, like trauma, but there's more and more shopping going on, particularly with younger people, which we'll talk about.
Great. Are there new technologies changing what people want from healthcare? For example, I use the Samsung smartwatch and the Aura smart ring. I'm using maybe 1% of the capabilities of this. Are we seeing a shift as technology is encouraging us to go to the next step?
Well, we are, and the proxy measure for that is the growth of digital health in the Consumer Electronics Show, CES, which is run by the Consumer Technology Association. So every January, I go to Vegas for 15 years. This will be my 16th coming up in January, except for 2 years during the pandemic. And we've seen the floor space in digital health growing like crazy every year. In the early days, it was Under Armour, Nike. CVS showed on and off for a while early on. And now the digital health space morphs with other areas, family health, sports tech, of course, wearable tech. So it's very interesting to see that as a proxy measure for the supply side of digital health. And then on the consumer side, as many as 1/3 of boomers and silent generation people are using at least one wearable, which came out of Rock Health's data just this week. In looking at the generational use of digital health, 32% of older people using a wearable, at least one wearable tech for health. So yeah, it's changed. Supply side meeting the demand side, not just for Gen Z, millennials, etc.
Let's talk about trust. Trust in digital engagement tools seems to be slipping. A 2024 Deloitte healthcare study found that 58% of consumers are concerned about device security and potential tracking. I know I am. Jane, what's driving the growing mistrust amongst consumers? And how does this influence the way consumers want to use or avoid specific technologies?
Trust is something I spent a lot of time thinking about for many years. I've collaborated with Edelman, the global communications company, looking at their annual study called the Trust Barometer, which comes out every January, just right after the Consumer Electronics Show, at Davos, the World Health, at the World Economic Forum. What Richard Edelman and the team have discerned in the last decade is that people's overall trust with institutions has been eroding year upon year upon year, particularly erosion of trust with government, media, and NGOs, non-governmental organizations like the UN, World Health Organization, what have you. The one institution where people continue to trust, though it started to erode in the last couple of years, is with business. But particularly the most valued is my employer. So you think about then, if we put a health lens on that, our employers, if we're lucky enough to have health insurance through work, we trust our employer to communicate with us health messages, to fund our health insurance or co-fund it, and even provide for increasingly mental health benefits, fertility benefits for both men and women. That's a growing area. But you have this erosion of trust overall, and this erosion of trust with health, though not all of healthcare, because we still highly value and trust the nurse, the doctor, and the pharmacist, which we get from a different research point, the Gallup poll of trust, ethics, and honesty in professions. And every year, far and away, nurse is number one. Nurse. And then pharmacists, doctors, pharmacists, depending on the year. But it's nurses, and it's this human capital, the front line, who is still trusted Again, year on year in the opioid crisis, pharmacists slipped a little bit. They're back up again. Hospitals, health plans especially have eroded in trust. We could talk about United Health Care or not, but as again, a poster child in the last year for an organization that's turned into the demonization, the way we used to look at big pharma, big oil, big tobacco. Now we're looking at big insurance, like a United, as an example. Don't mean to beat up on them, but they're the plan that we have the most media coverage on.
Do you mean the one that was just potentially indicted on Medicare fraud? Is that the United?
Yeah.
Okay, got it. I just want to make sure. Now, it's interesting, Jane, you didn't mention hospitals and health systems. And it appears that with the lack of trust, some retail brands, CVS, Amazon, Walgreens, have been stepping in. Retail health seems to be raising the expectations and changing how people want healthcare delivered. What mistakes are hospitals making when trying to compete or partner with retail health?
So the opportunity is so great for local regional hospital systems to partner with these beloved retail brands. Now, we have to look at new data just out this week, and this week is May 20th, the week of May 20th. New data from when we're recording this. New data from Ipsos Harris every year looks at brand equity. What brands are up, what brands are down amongst U.S. consumers. And in the last year, there's been a huge erosion of brand equity or brand love amongst U.S. consumers with the big retail pharmacies. CVS, Walgreens, obviously Rite Aid's in big trouble. Bankruptcy. So we then, though, can turn to retail pharmacy in the grocery store. My holy grail as a health destination during COVID, the grocery store with a pharmacy, with a retail clinic, and a nutritionist to help us build a healthy grocery cart. That pharmacist became a quasi health consultant or health coach in COVID. We could talk to them through the glass with a mask about over-the-counters or prescriptions. So I think the great opportunity right now for collaboration and a health trust halo is for local regional hospital systems to work with these big chain grocers like, and I have no skin in this game, so I'm going to say names.
Yeah.
Kroger Health, for example. Kroger Health, unbelievably involved in food as medicine. And that's where we bring it all together for empowerment, because people really are looking to food now as a medical complement in a holistic way for energy, for brain, for sleep, for sex lives, for whatever. So I'm watching that space. I'm doing some of that kind of work in Europe with a big food group. So this is a real thing now. People really wanting to connect the dots between my medicine, my food, my whole health for me and my family.
I think you're onto something. For those of us who have problems controlling our weight, I just went on a GLP-1. I'm actually watching what I'm eating, and now I'm really attuned to the ingredients. And it's been really helpful when I'm going in the aisles of Safeway or even Costco, having somebody educate me on what I should be staying away from, even though it feels really good for me to eat the bag of potato chips. I am avoiding it.
You know, GLP-1s, and I've been covering it for another client, looking at the landscape. And what's fascinating about GLP-1s is it's totally disrupted adjacent markets, not just in healthcare. So obviously grocery stores, salty snacks, sweet snacks, right? Center of the store, really getting hurt, snack foods. But we're looking at vitamin mineral supplements. So what GNC's doing with a whole GLP-1 kiosk. Smoothie King, the chain that makes smoothies, has a GLP-1 menu for smoothies, protein-infused smoothies. You mentioned Costco. You know, these are the places where people go. And people project manage their life, their health. So it's really interesting, GLP-1s as a case study for how it's even impacting hospitality, hotels, airplane seats, clothing, obviously. So athleisure wear for women and men. Fascinating. It's disrupting and creating new opportunities, but also people like Pepsi and Coke, who have snack divisions, are like, whoa, we've had to change. Danone, which is Danone in Europe, who I have worked with. We have Activia in the US, you know, for probiotics, but in Europe, Danone is really a nutrition company and really watching what's going on with GLP-1s. So yeah, watch that space.
You're onto something big. There was an article in the Wall Street Journal this past week about this exact topic on the impact it's having on a lot of the snack food vendors. It's also having a negative impact on hospitals who are dependent on chronic disease. So we really are in a very disruptive period right now, and it could be an opportunity for innovation for health systems on healthier living.
You know, yesterday, my blog, so that would be my blog, Health Populi, dated May 21st. I mined a study from Monagle, which is in the business of brand experience across all industries, but their health report came out this week. And the key thing for health systems in that report was patients as consumers want wellness from the hospital system coupled with kindness and efficiency. But it's wellness. It's not just take care of my heart failure or my type 2 diabetes. It's get me well and keep me there, hospital system. And also at the same time, be personalized, be kind, give me time and respect me, and be innovative with AI. So it's really interesting. The demand is there for wellness for hospital systems. And the only way hospital systems can do that is to collaborate with companies that have the wellness mission too, like food, exercise. Yeah.
I will take issue with one thing you just said, kindness and time. As long as it can fit in within the 5 minutes. It's kind of hard to actually portray that because I have a nutritionist at my local health academic medical center. I also have a fat person coach, and they give me enough time, but I wouldn't say it's really engages me as much as it could. So I rely on ChatGPT to advise me.
You know, if we pay for healthcare differently, another discussion on the basis of value, more time will be spent, more digital devices will be prescribed, more telehealth, more virtual care, more dietitians and mental health people in the mix to help keep me holistically well so everybody does well under value. But we're not there yet. But really, it's about the payment when it comes to time.
This is a hot topic, especially in our current political climate, is are all patients or consumers treated the same? So maybe we should talk about health equity. Why are hospitals falling short when it comes to building access points to underserved communities and individuals?
It's a huge question. I do spend time on this in my work. Health equity, a girl who grew up in Detroit, one of the first had busing into my school district. And so it goes back. And I did my graduate thesis in Detroit, working on access issues a long time ago for girls' health, women's and girls' health. There's sort of an ugly underbelly we don't talk about a lot about racism or bias that could be either overt and implicit or complicit. Some people were trained in different ways to deal with different patients and aren't always trained in terms of cultural competence to understand. Assumptions are made, even assumptions made about women versus men, women complaining versus men being stoic. Like that isn't always the case. So, I mean, we've got inequities and disparities of many ilks. Ageism versus pro-young, obviously different ethnic kinds of biases in different places. And this tends to be very local. So it's a U.S. problem, but certain markets geographic markets are more integrated, more cosmopolitan, more aware than others. So you see pockets of health inequities, and some hospital systems have wrestled with this really well, and some have not done as good a job. And right now, this topic is so rife with politics. If we use the acronym DE&I, that's no good right now. So we have to couch it in other language. But the problem still persists. And health equity costs a system and a society money. So I just gave a speech about this a few weeks ago about the costs of health inequity. And Deloitte did a study a few years ago, and they forecasted that it could cost the U.S. health system as much as $1 trillion in 2040, based on the fact that we're not treating people with modern protocols across the board. You can measure this for, say, diabetes, heart failure. They looked at 4 or 5 disease or condition categories and did the actuarial forecast. So health equity is not only a nice to do to deal with it, but it actually has an ROI. if we deal with it. If we treat people with modern protocols, with modern medicines, access, get the people in, coach them, etc., get people the support they need, including food, and we think about, say, SNAP benefits, which are really important for a lot of people. So health equity, I think, is everybody's business because there's an ROI on it. And it's also something, as my mantra about health citizenship would portend, we need to care about each other, not just because it's a nice to do or because we're faith-based people, because it actually saves money and resources for taxpayers and others in the end. So, and I think it's just better to be kind, but also smart. Hard head, soft heart. It can work. It works in a lot of places, but we haven't mastered that yet in the United States.
Actually, that was the question I was going to ask you is when you look at a lot of your clients across the country, would you say that they're making the necessary investments, or is it more the anomaly? Maybe only 5% of hospitals and health systems are making their tools accessible and fair, not only for the high-tech executive in Palo Alto, but what about the immigrant worker in Bakersfield, California?
You know, there are some incredible, we'll start where this gets funded. We follow the money when you're me, an economist. There are some governors who expanded Medicaid and provide really innovative programs to provide healthcare services when that and education are the top two line items for a governor, and governors have to balance their budgets. So the governors who want to provide health benefits to their health citizens of different states, and you can look at Andy Beshear in Kentucky as a really good example of a guy leading a state that isn't all Democrats, for sure. But he's done a great job reimagining what Medicaid could do in his state. And you've got a lot of people with health literacy issues, trust issues, smoking, obesity, etc., public health issues, social determinants of health risks. Those governors then fund healthcare, fund Medicaid in creative ways so that all of a sudden you might have populations of people who are gifted access to Wi-Fi to manage care at home. And we have to be really creative now because Wi-Fi is a social determinant of health. We need access to connecting to health providers, mental health providers, schools, looking for jobs. It's all online now. So if we don't have that lifeline, which is Wi-Fi, there really is a lot of health that's compromised. So again, I can tell you there are Medicaid programs, Medicare Advantage programs, etc., and certain health systems. A good example of a health system really thinking in this kind of way would be Michael Dowling at Northwell Health in New York City. And I just read he's retiring, and he's like my gold standard. So we need more Michael Dowlings in the world. But there are innovative thinkers who are reimagining what healthcare delivery is in terms of food pantries and gun safety and family care and mental health to the home, to the individual. So they're out there. I can't give you a percentage. You said, is it 5% of systems? There are examples all over the country in big states, red states, blue states, rural areas. And these are the leaders we have to look to share their knowledge and their inspiration to everybody else.
I know we're running out of time here, but I'd love to ask a big question. What's the one thing that hospitals could do tomorrow to rebuild consumer trust? And what's the one thing hospitals should absolutely stop doing today?
Well, I think hospitals, the second point, I think hospitals should agree to get paid differently in terms of value and really figure out how to do things differently. That it's a forcing equation. When you're paid on value, you start to adopt new ways of doing things, create multidisciplinary teams, dietitians, mental health, etc. To the first part, which was what should they do? So we haven't talked about the role of design. So let's talk about why design is important in terms of person centricity. And when we think about the multi-layers of design and experience for both consumers, patients, caregivers here, and clinicians and providers, we have a hurting, H-U-R-T-I-N-G workforce of nurses burning out, doctors burning out, and pharmacists and ancillary care providers. providers. So we've got to think about how do we deliver a better experience for people providing the care and the experience for the person, the patient, the caregiver, who's super important, the friend who's helping take care, for their both clinical experience, so the UX, user experience, then the service design. How do they get through the system? Is the EOB pretty? Do I understand it? Am I treated with respect vis-a-vis time? So you've got different layers of design, UX, CX, service design, and then design for the workforce. So we have to think about in a phrase, the quintuple aim: lower cost per patient at the margin. Some people are more expensive, just so do what you can do at the margin. Drive a better experience for the patient and the system itself. Drive to population health outcomes. And then the two new legs, the fourth quadruple leg and the quintuple leg, are the quadruple leg, the burnout amongst clinician well-being. And the fifth is what we talked about, health equity. How do we deal with health equity? Those are the 5 parts of the stool that are true north for the quintuple aim, and that kind of concentrates the mind.
Wow, that's awesome, Jane. Keith, do you have any thoughts that you'd like to ask Jane about, or love to get you involved here?
Yeah, thanks, Greg. And thanks, Jane. I really appreciate the perspective of all these stakeholders working in community. So you talked about large employers, you talked about the retailers in the community, you talked about the health plan, the health system, the provider, all these stakeholders coming together with an aligned mission for your health, like driving towards a focus on your health, not just treating you when you're sick, but all those other times in between. To have, as you gather new information, creating sort of an environment of shared decision making where that new information may cause you to be somewhat flexible in your plans moving forward. And then to just the transparency. It's really, I think when you guys were talking about kindness and Greg was saying, well, he kind of needs tough love. He doesn't just need kindness. I think that's about transparency, right? So I mean, I guess that's what I heard. Is that a fair assessment of what you were giving us?
Yeah, I mean, to that point, research done by Judith Hibbard many years ago with the Oregon Health Plan, group health plan in Oregon. She was into patient activation in the early days of patient engagement. And she did research that found in the exam room between a patient and a doctor, for patients dealing with type 2 diabetes, if the doctor gave the patient instructions to manage their HbA1c this way, this, that, and the other way, if the patient felt respected in the room with the clinician, when they came back a couple months later, their H1C was better managed. They stuck to their meds. They felt the return on respect between the clinician and the patient, really important. And it works the other way too. Patients have to show respect to clinicians, and it's kumbaya. And that's the relationship we want to preserve. The last thing before we go on trust in local communities, there's a great opportunity for that health provider to be the trusted source of information. So we're in a misinformation mode when it comes to vaccines now, for example, or science in general. Who is trusted for that? An academic researcher and a scientist, and then friends and family. Well, where's the hospital system? We're not just talking about Mayo and Cleveland Clinic. We're talking about your local system should be a go-to place for you to build health with your family, with your community. And so I think there's a really great role the hospital can play, partnering, of course, with WebMD, with Medscape, with whatever information provider. There's tons that they can do with different providers, or the academic medical center down the road, who, again, they're collegial with already with patient sharing. So I think this issue of trust and misinformation is huge right now. And so that's another role our local providers can play to rebuild that.
Jane, one thing you brought up that really resonated, you brought up the personal relationship with the provider. And as I was doing my study on patient engagement, the issue came up is we know through the Robert Johnson Foundation that if I have a personal connection that engagement works. But what about if it's pure digital? Can I just have a purely digital relationship and does it have the same impact?
I think we're in an interesting changing mode right now. If you look at Gen Z, and that's where we look to the future, that's part of my work in forecasting, is you have to look around the corner. So a lot of Gen Z consumers are saying, I'm not happy with the way the health system is, and I am going to use ChatGPT. I am going to have a digital coach and access my records through a blockchain system, whatever. I think we are coming to a reckoning now with what will the role of a personal physician be. And I think it will be largely digital. I think things will get diagnosed and you'll have an in-person relationship at a diagnosis, and then you'll be sent off perchance to self-care and to deal with chronic care online. So it will be a mix, and people will be motivated in different ways. But I do believe there'll be roles for health coaches, for nutritionists, for a new factorial healthcare team beyond just the doctor, nurses playing more role, pharmacists, the grocery, etc. So I think it'll be more multi-mode, and we didn't use the word omni-channel yet. So let me just throw that in, because people want care and services delivered when they want, how they want, and we got used to this in COVID, and that's sticking. So we want omni-channel care through the phone, through the computer, in person, buy now, pick up later, etc. And I think we have the technology now to really do this. AI can help. So I'm really looking forward to that, serving up a more retail style healthcare experience the way people want to receive it and engage with it.
Love that last point you brought up. I think today we have more multi-channel as opposed to omni-channel. I wish every channel would kind of coalesce together, but it seems like each channel is independent,
Yeah, it has to be platformed with the person at the center, all those touch points. And it's a design thing, but it is doable and it's being done.
Jane, this has been an outstanding conversation. You always deliver. So thanks for sharing your insights.
Sure.
For listeners who want to get in touch with you or learn more about your consulting work or your industry talks, your publications, how can they reach out to you?
So the unified field theory is all on my blog at healthpopuli.com. Find me on LinkedIn. You see the spelling of my name. I will always write you back. If you connect with me, I'll connect with you. But the blog is my whole brain trust. Since 2007, there are over 3,000 posts only written by me in my voice. I do not accept advertising. It is totally independent. You can see I'm very independent. That's my business model. And I work across the ecosystem. So if you like that kind of approach, that's where you find me online.
Jane, you are a legend. Thank you for coming.
Thank you.
Thank you for listening to Beyond the Blueprint. Together, we're exploring how thoughtful design can simplify complexity, enhance patient care, and create meaningful change. If you found value in today's episode, make sure to subscribe and leave a review in order to help us continue the conversation. Let's reimagine healthcare together on Beyond the Blueprint.